Right. Assalamu alaikum. Good afternoon, Farid Ahmed. First of all, I would like to thank organizers for allowing me to come to the podium for the talk. Uh, this is me. Without much ado, I'm going to move on to my topics today. Axillary management after neoadjuvant therapy, the de-escalation strategies. The question is why this matters. The role of axillary surgery is evolving in the era of more effective neoadjuvant system. And historically, extensive axillary dissection was carried out up to level 3 for node-positive breast cancer, but now the paradigm is shifting. De-escalation offers a lot of potential, like fewer complications, like lymphedema, shoulder dysfunctions can be quite less, and obviously better quality of life. Oncological safety must be maintained. The key question is, after neoadjuvant systemic therapy, which patients can safely have less axillary surgery, and how we should select those patients. Now, neoadjuvant therapy involves chemotherapy, plasma-targeted or immunotherapy drugs. It's increasingly used nowadays for early and locally advanced breast cancer. In node-positive disease, clinically node-positive, neoadjuvant therapy may convert many patients to pathologically node-negative YPN not status. So I'll be using this nomenclature for my further slides as well. That conversion opens the possibility of reducing the extent of axillary surgery without compromising regional control. Historically, as I've mentioned, node positive always is axillary clearance. Even after chemotherapy with complete response, we are still currently practicing axillary clearances, but it has got associated with up to 25% lymphedema risk and other comorbidities. And these are some photographs of quite debilitating conditions of lymphedema significantly affecting quality of life. And again, axillary web syndrome, as you can see in your day-to-day practice, the surgery can damage the connective tissue surrounding the lymphatic vessels, and that can cause hardening of the tissues and cord-like webbing, which we come across with quite challenging to manage. Now, some of the definitions and key techniques I'll be using during my slides, like ANCs as axillary nodal clearance, SLNB or SNB, sentinel lymph node biopsy, which limited nodes are removed, which has got less morbidity. TAD, targeted axillary dissection, in neoadjuvant setting, involves the removal of previously marked positive node, either with a clip or a seed. And then we do sentinel biopsy while you do breast surgery post-NSCT. MARI, marking axillary lymph nodes with radioactive iodine. So it's before neoadjuvant chemo and then remove at surgery. De-escalation, what does it mean, de-escalation? So reducing the extent of surgical radiation intervention without increasing the risk of recurrence. So this is quite important, without the risk of recurrence. True de-escalation means also not to escalating some alternative therapy to compensate. For example, like I've done a breast conserving surgery, a radiation oncologist will cover everything like breast, supraclavicular fossa, axilla, internal mammary chains, and if not other breast. So you have to be careful to that. The recent systemic review, I think it got published in July 2025, and meta-analysis found over 4,000 initially node-positive breast cancer patients who converted to nodal pathological complete response and avoided axillary nodal clearance. The recurrence rate was 2.1% for SNB groups only, and 1.5% for MARI or TAD cases. Now, in conclusion, we can safely say, based on these evidences from the trials and review analysis, meta-analysis, YPN not with post-NSCT node-negative patients, omission of axillary nodal clearance appears oncologically safe. The caveats: heterogeneity of studies, follow-up duration vary, and patient selection is also very important. Now, the question is, who are the candidates? And again, patients with initially clinically node positive, patients who convert to clinically node negative after neoadjuvant chemo, they must have accurate nodal assessment, because this is quite important. The accuracy of through imaging, physical examinations is quite important. The techniques like clipping the positive nodes pre-neoadjuvant chemo, then retrieval. So all these techniques requires lots of skills and other supports. Some factors influence residual nodal diseases as well. And also, multidisciplinary decision making is key in everything. And it has got proven benefit of better survival if we could use this multidisciplinary decision making process. We need to evaluate systemic responses, tumor biology like HER2 positivity, triple negativity. They have a better or higher rate of pathological complete response. Now, pre-NSCT or neoadjuvant systemic therapy, biopsy-proven axillary metastasis, you clip or seed the positive nodes, and then after chemo, image and clinical assessment is done. And at surgery, after breast, when you do axilla, you perform sentinel lymph node biopsy, at least 3 or more nodes, ideally, if possible, and remove the marked node as well. And then we do targeted axillary dissections. And if negative, you can omit axillary nodal clearance. And if residual disease, you can escalate to axillary clearance or radiation. So dual tracer for central biopsy is ideal, and blue dye and radiocolloid or other measures. Here in my unit, I've got 472 cases of central biopsy, where I found 4 cases with recurrences and in last 6.5 years. And I have used 2 dual tracer dye technique only, which appears to be safe, but requires further studies. Coordination between radiologists and surgeons is essential, and this is just one of the picture. I've shown this before, how we do the sentinel lymph node biopsies. We use 2 types of dyes here in Dhaka. Only few cases when I was working in Evercare, I was able to use nanocolloids, but my current work practice, I don't have the facilities. I just use 2 dual tracer dye techniques, which appears to be safe based on the current evidence I have got from my database. Now, this is a picture where you could see a patient has got a wire inserted in the axilla, but prior to starting chemotherapy, patient was inserted on the positive nodic marker clip. And post-neoadjuvant chemo, with ultrasound guidance, the wire is inserted, as you can see, where surgeons will follow the wire and take the nodes out, which is clipped already pre-NSCT, and that is the role of preoperative axillary lymph node marking with a clip in breast cancer patients, and the benefit, one of the examples of TAD. And targeted axillary dissections been tried also, other options like carbon marking for patients with node-positive breast cancer patients before commencing neoadjuvant chemotherapy. The TATCOM study, these are the protocol, has been ongoing. In fact, we don't have much major multicenter research evidences, studies for patients neoadjuvant post-NSCT, the management axilla. Some of the trials are ongoing, which I will come to that later on. The role of sentinel lymph node biopsy for breast cancer patients who become clinically node negative following NSCT, a large number of studies have evaluated the oncological outcome. The sentinel biopsy in breast cancer, clinically node positive patients who become clinically node negative following chemotherapy, it shows a safe procedure for patients, and it's showing good prognosis and low axillary failure rates, which is also evidence in my current practice in Dhaka as well. Targeted axillary dissection proposed to minimize false negative rate has not demonstrated a prognostic advantage over sentinel biopsy alone. As a result, axillary surgery is moving towards a de-escalation, and some ongoing studies are attempting to assess whether a reduction in axillary adjuvant radiotherapy is possible. So, radiotherapy and axilla, the role in de-escalation. I'm sure our radiation oncologists will be interested in this part. While surgical de-escalation is promising, radiotherapy management of axillary remains part of the strategy. And some argue that omission of axillary nodal clearance must be accompanied by nodal field radiation to maintain safety, but that may limit the true de-escalation. There are ongoing trials like Energy Oncology and SBPB51 RTOG 1304 are evaluating whether nodal radiation can be omitted in YPN node after neoadjuvant chemotherapy. Important is to remember is to integrate surgical and radiation planning when considering de-escalation. This is quite important. There are other trials ongoing, Alliance A011202, where it's a phase 3 randomized trial comparing axillary lymph node dissection to axillary radiation in breast cancer patients, clinically T1 to T3 and node 1, patients who have had a positive lymph node disease after neoadjuvant chemotherapy. This is being done. I think 1,660 patients will be enrolled to that, and is ongoing. And we are still waiting for the results. It's just I haven't seen it, to evaluate whether radiation to undissected axilla and regional lymph node is not inferior to axillary lymph node dissection with radiation to regional lymph nodes, but not to the dissected axilla in terms of invasive breast cancer recurrence, free interval in patients with positive lymph nodes after completion of NSCT. The pitfalls of unmet needs. Accuracy of staging after NSCT is critical, which is a bit of challenge for this part of the world as well. False negative rates of SNB alone in clinically node positive patients turning into post-NSCT node negative setting may be higher unless technical safeguard is applied. This is very important to remember. The lack of long-term follow-up in many de-escalation cohorts. Heterogeneous definitions of nodal positivity, pathological complete response, imaging modalities, adjuvant therapy across studies. Application in LABC remains limited, and we need tools to predict residual nodal diseases through imaging biomarkers to refine selections. Now, there are some proposed algorithms which I've already gone through. I'm not going to repeat those. And there are some proposed algorithms, some trials in clinical practice. So one is the UBreast O3 XNI study. As you can see, these are the flow chart. And it goes on for clinical practice, the proposed algorithm. There are a few more examples where T1 to T2 node positive patients, triple negative or HER2 positives, neoadjuvant chemo, they've been divided into two groups. One is clinically node negative, one is clinically node positive. And then clinically node negative SNB is done. If node negative, then obviously radiation. If node positive, they get transferred to Alliance trial. And if the node negative after post-NSCT, they go for either axillary nodal clearance or radiation. Same examples, targeted axillary dissections after NSCT for highly selective patients with an initial C1 breast cancer. A single center prospective trial has got similar proposed algorithm clinical practice. And I think it is in Spain, Barcelona, their ADRENET trial ongoing for trying to look out for a same answer, that axillary lymph node dissection versus radiotherapy in breast cancer with positive sentinel lymph nodes after neoadjuvant therapy, and we'll be getting some answers in future as well. And some of the studies where, if you look at the summary, where you would see the de-escalated approaches shows very low axillary recurrence if you properly select those patients. So this is quite important. Now, implications for surgeons and oncologists. Surgeons need to collaborate with radiology, like proper accurate clip replacements of the nodes, nuclear medicine support, contrast if using seeds, and ensure techniques like at least 3 or more sentinel lymph nodes should be taken out, and try to use dual tracker techniques for better accuracy. For oncologists, recognizing that achieving the nodal pathological complete response allows discussion of less extensive surgery, ensure systemic therapy is maximized. Radiation oncologists, input into the axillary radiation decision is critical when axillary nodal clearance is omitted. For everyone, de-escalation is about balancing benefit and risk. Selecting the right patient is key. Institutional protocols and prospective data collections are recommended for a center offering de-escalation. It's quite important. Future directions and trials. There are ongoing trials, which I've already mentioned. Need to improve imaging and biomarkers for residual diseases through dual energy CT or MRI. And we have a little bit of problem in this part of the world about this. Long-term outcome is quite important, 10 years or beyond for de-escalation cohorts, expanding beyond clinically node-negative patients to post-NSCT node-negative patients to identify safe subsets among clinically node-positive patients who have partial response. Quality of life is quite important, which is often overlooked in this part of the world. Lymphedema incidences, arm dysfunctions as primary endpoints in future is to be looked at. Multi-center registries and real-world data is critical. My unit, I have got more update, but till August 2025, from June 2019, I've had almost 8,000 patients. Breast cancer, I had 2,040 patients. And breast conserving surgery has had 472 cases. And mastectomy, I've done 300, just over 300 cases. In axillary nodal clearance, 503 cases are done. Central biopsy, 472. Out of them, there are patients with neoadjuvant chemotherapy. Some of them are pre-NSCT nodes are negative, but still they had SNB. And if the SNB was positive during Fresnel section, during surgery, then we'd proceed to axillary clearance. That is the current practice. But hopefully we will be able to move forward with further de-escalation process. Take-home messages. Modern systemic therapy has changed axillary management possibilities in selected patients like clinically node positive, clinical post-NSCT node negative, de-escalation of axillary surgery, SNB or targeted axillary dissections may be safe with very low axillary recurrence, 1 to 2%. Important prerequisites are clip, marking nodes, adequate central biopsy techniques, multidisciplinary planning. So these are the 3 important prerequisites. Now, axillary nodal clearance omission is possible, but must be accompanied by careful patient selection and follow-up. Surgeons, oncologists, radiation oncologists must collaborate. Ongoing research will refine algorithms until institutional protocols and data collections are key. Less is more. This is the ethos, and we should be working on it in every sector without compromising patient safety. Let's work collaboratively to achieve shared future goal, implying unity, collective effort, and optimism for what is to come. Let's come together, rewriting the future of breast cancer care in Bangladesh, where the needs of the people and communities come first. Thank you for listening.
Thank you, Dr. Sk Farid Ahmed.